And Professor, how much do you estimate this to cost for a patient?
Well, that's a good question. We don't know at this point because there is so little evidence and no evidence of cost benefit. These are not treatments that are currently funded, so there's no Medicare funding other than minimal funding for the therapist time. We don't know whether private health insurers will fund this. And just a broad estimate, knowing that the substances have to be imported from overseas, they have to be managed within a pharmacy system, and just the amount of time required from the psychiatrist and the therapists, estimates are somewhere between sort of $15,000 and $25,000 for a course of treatment, with probably almost nothing back from any other source of funding.
And again, Professor, we talk about it being early days, you require funding. And in terms of a patient, how much rigorous assessment do they need to go through to actually get the go-ahead for this treatment?
Well, these would be patients with existing conditions. So they would be, PTSD is a very unpleasant condition with very disabling symptoms, and also, unfortunately, is quite common in the community. So, these are patients who would already be under the care of a psychiatrist. Same thing with treatment-resistant depression. Having a type of depression that doesn't respond to other treatments is very unpleasant. So these are people who are already under or should be under the care of a psychiatrist. And it's really up to that psychiatrist to discuss with the patient whether referring you for this type of treatment would be the right thing to do. Other points to make would really be the authorized psychiatrist, or the psychiatrist who's going to provide the substance, has to gather together a team, has to source the substances from overseas, has to put all of those proposals to an ethics committee, who then approves what will happen. They then take that ethics approval to the TGA, and the TGA look at what their proposals are and then issue the authorized prescriber status. And then within each state and territory, the prescribing psychiatrist would have to apply for a permit to treat the specific patient with that substance in a particular location. So there's, if anything, the amount of work that it places on the psychiatrist who's prescribing is quite considerable.
And Professor, we hear other treatments such as ketamine, again with the patient and psychiatrist, and with the product. You're the expert. You could tell the audience much more than I would know. But in terms of this type of therapy, do you see this moving more forward in the future?
I guess we are keen to find any effective treatments, hopefully, and part of our recommendations and guidelines is that comprehensive data needs to be collected as part of these treatments, including extended follow-up treatment. So we are aware of some signals from ketamine trials that when the ketamine treatment ends, patients can return quite quickly, quite suicidal. So part of our recommendation is the same for this treatment, is that beyond just the course of treatment, patients must be very carefully followed up to make sure that there are not some late adverse events occurring that we need very much to be aware of. But if we can prove these treatments work, then yes, they would be a real paradigm shift to how we practice psychiatry and could offer some promise. But the data isn't quite there at this point. But we do have this new down scheduling that just makes it slightly easier for, researchers and clinicians to implement these treatments.
All right. Well, we really appreciate your time and expertise, Professor Richard Harvey, and we look forward to hearing more. Thank you very much.